I request another dynamic surgeon from Jaipur, Dr. Vishal Agarwal, to please go with his talks on myopic tractional Foveoschisis. Over to you, Vishal.
Natarajan sir. I'll be discussing about myopic tractional Foveoschisis. Just a brief pathological myopia, as we all know, is global elongation and a refractive error of more than -8 diopters of refractive error, or a axial length of greater than 26.5 mm. And it has a high disease burden. Myopic Foveoschisis is about 30 to 40% of patients having more than 8 diopters of myopia. It causes excessive axial elongation, resulting in mechanical stretching and thinning of the choroid in the RP layers, leading to multiple problems like posterior staphyloма, RP atrophy, cracks, CNVM, foveoschisis, and finally a myopic macular hole also. So I'll be discussing the surgical aspect of myopic foveoschisis and few tips and pearls to manage these difficult cases. So there are four problems in these cases, and we'll look upon them one by one. The first is visualization. Second is PVD induction. Length of the eyeball is a major problem in these cases, and a common basic technique to get consistent results. So even a small amount of lenticular opacity in these cases causes a lot of spherical aberration. So it's always a good idea, even if there's a small amount of cataract, the patient is around 45 or 50 plus, you do a combined phaco-vitrectomy. And because the ILM is so thin and friable in these cases, absolute crisp view of the ILM is necessary, which will not be able, which is not possible through a media hair. So always you can go with the phaco-vitrectomy, so as to catch hold of the ILM in a better fashion. You can see I'm sorry about the quality because it's a projector system, but the ILM was absolutely clear in this case of a phaco-vitrectomy. PVD induction is very difficult in these cases. So there are two subgroup of these cases. One is 29 mm of axial length or less, and one is 30 mm or more. So this case is of a 28.5 mm axial length. As you can see, the cortical vitreous is absolutely stuck in this case. So this technique we use in our pediatric detachments also, and now we are using it routinely in myopic foveoschisis. So you do a core vitrectomy, you stain the vitreous with tricot, and you inject a small bubble of PFCL over the posterior pole, and you just make a small cleavage of on the hyaloid face, and you just enlarge it with the blunt instrument like a light pipe, like I'm doing it here, and the whole PFCL bubble goes inside that space between the hyaloid and the retina, and you just keep injecting more, and atraumatically the hyaloid cleaves till the equator, and then the rest of the job you can do with a cutter. But that is not a good idea in high myopes more than 31 mm, because the axial length is already very high, and if you inject PFCL, it will artificially increase the axial length more. So there's no way out. You have to be persistent, patient. You have to hold the hyaloid with the forceps, cutter, a mild section repeatedly, and after a lot of patience and hard work, it will come out. But before that comes out, you cannot proceed to other procedures like staining or peeling of the ILM. So this is a very important step, and it has to be done patiently without creating any iatrogenic triggers. The third is the how to circumvent the length problem, because the instruments are not meant for such long eyes. So one is that you can use again the bracket of 30 mm or more eyes. You can use the irrigating lens. In that case, if you are using a contact wide angle, your shaft will not touch the shaft of the forceps will not touch the wide angle lens. If you are using a non-contact, it will be very vertical, and the shaft will touch the rim of the non-contact wide angle system. So irrigating lens, macular lens gives excellent resolution and magnification in these cases. Of course, in patients having 29 mm or less axial length, you can use the non-contact wide angle system. The other way around is you can make your ports more posterior, around 4.5 mm. You can remove the cannula, or you can use your left hand if you're ambidextrous, because your left hand might reach the posterior pole better than the right hand in these cases. These cases often have recurrences, and this was a recurrence of myopic tractional maculopathy. I operated around 1 month back, and this was referred to me because of incomplete hyaloid removal. You can see the whole macula is puckered, and the important point about these cases is that these membranes are not stained with tricot very properly. So you have to use the blue stain, a trypan blue, repeated stain with trypan blue. You have to keep it a little longer, for around 30 to 40 seconds to get adequate stain. As you can see, the whole membrane was removed. And the second point is that once the ILM is visible, you have to peel it till the posterior staphyloma edge. Otherwise, the retina will not be redundant or pliable enough to get settled in the postoperative period. Even if you attach the retina a suboptimal result like a type 2 closure can occur. So I'll just tell you the last video in which we have devised what we follow routinely in all myopic foveoschisis cases. This was a myopic foveoschisis with a macular hole, one-eyed patient, pseudophakic. I'll skip the animation. So here the PVD was already there, but still we need to confirm it again by restaining it with trimestone acetonide. Once we are sure that there is no PVD, you can see the posterior pole is quite bullous. There is a subretinal fluid, and we stain it with trypan blue, we stain it with brilliant blue multiple times to get hold of the to catch hold of the ILM. And because the posterior pole is quite bullous, we inject a small amount of PFCL just to flatten it. And here we once we catch hold of the ILM and fold it back, then there is not a problem, because now it can be seen against the poor contrast of the sclera. And we do inverted ILM flap. We peel multiple flaps of the ILM towards the hole. We don't exactly stuff it inside the hole, just give it a gentle tug. And again, the common point is that the area of the peel should be wide enough to include the curvature of the staphyloma. If that is not done, the retina will not be pliable enough to get settled, and the hole will not close in the post-operative period. After that, the whole ILM is bunched towards the hole, and the PFCL bubble is gently aspirated. So advantage of this technique is that we have avoided making a retinotomy to drain the posterior pole fluid. And if there are no additional slit breaks on the posterior pole and the macular hole was the only culprit, this fluid will be gone by the next post-operative period. Gas suffices in this case. We inject C3F8 gas with excellent results in the post-operative period. So to conclude, myopic tractional foveoschisis is a complex surgery with varied intraoperative surprises, and a thorough preoperative workup and planning is needed. And combined procedures, complete PVD induction with multiple staining and posterior ports that is the key to success. But the bottom line is a thorough preoperative counseling with a very clear communication about the chances of failure and late reopening of holes and modest improvement of vision should be done to the patient. Thank you so much.
Well, for wonderful videos as usual. 5 minutes are left and we have 2 more talks. Next week call upon Shilpi to... The only different thing I do, Vishal, is I still, if the detachment is outside the arcade, I will, do a small retinotomy because RP is not very healthy in these people, so it may take longer time to absorb.
Just one last question. Is ILM peeling necessary in all these cases of tractional myopic foveoschisis? Recently I burnt a hand doing an ILM peel, and then it opened up. It caused a large macular hole
only 4
in the
minutes are left.
foveoschisis. So